your sound down. There you go. So thank you very much, guys. So this is week 3. And as you have seen, these have been very well attended seminars. Fanie, Yaseen, very welcome to us for today. You're going to have a very enjoyable session. They are called stars for a reason, because they are stars and they are some very good questions. And they're from how many countries? 14 countries? 16 countries, wow, okay. And there's a corresponding group in Senegal at IPD, many of whom will be online now, as well as in the last few weeks, there's been over 100 people from across Africa dialing into these seminars. Today, we're going to do differently. Previously, we had a small company here and followed by the African perspective. Today, we're going to turn it around, and Fanie's going to go first, and then we're going to have Yaseen talk afterwards. And we have 2 speakers on a very important topic. Digital health is seen by many people as the one area we can really leapfrog and transform the health system in Africa. The problem with digital health, as both speakers will tell you, is it's very difficult to sustain. Okay, and my experience in this, and I'll talk a little bit more when I'll introduce Yaseen a little bit later on, is that everyone that I have seen, and I would say 90% of the people setting up a digital health company, you effectively need a teenager who can code. So it's easy to do. And then the question is, what is the content? So if you're working in health in Africa, you can't develop an app that works in one hospital but doesn't work down the road at another hospital, or has one unique identifier for a patient, and then down the road, somebody has another unique identifier. That is no use to any health system in the world. It will be a nice project that goes nowhere because you can't sustain it. So Fanie's going to come and talk a little bit about from his experience working all across Africa and talking about his role now and the opportunities and the lessons he's learned at a continental level. And then Yaseen's going to talk about EMGuidance, which is a very cool project, but they went through everything that a lot of the innovators go through, and they are probably getting to the other end of it now where they have a sustainable business. So this is a very important session. Thank you both for giving up your time. And finally, I'm going to ask you to use the mic, because we get people online. Wow, you really are guru. He was so keen to meet you guys, he arrived 2 hours ago. So,
wrong timeline. Thanks.
So over to you. Can the people online hear? I beg your pardon. Give a thumbs up. They can hear. Thank you very much.
Thank you, Richard. You've basically done my presentation, so I can go home now. Excellent. Can you guys just confirm that you can hear me? Hear me as well? Perfect. Good morning, everyone. My name is Fanie Hattingh. I'm a medical doctor based here in Stellenbosch. And yeah, Richard, thanks for the opportunity to speak to this group of people, and the people online, very welcome to join us as well. Just to start the presentation, just to declare that I don't have any conflicts of interest. I do work for a big corporate company called Mediclinic Group. We have operations here in South Africa, Southern Africa, in the Middle East, and in Switzerland. And I'm working in the Southern Africa business in the digital health team at the moment as a doctor responsible to roll out our electronic medical record system over the next couple of years in South Africa. But this is just a little bit of where I am at the moment. And then just 1 or 2 other things. So I've used a couple of pictures. Just so you know, all of the pictures of people and patients are AI generated. So there's no real patients in the presentation. And then I'm really going to try and stick to practical examples and things we can take home. So it's not a scientific and a deep academic presentation. It's really around what I've learned practically in South Africa and Africa over the last 15, 20 years. I'll start with this picture, and I'll pose a question to this audience. Can anyone tell me how many countries we have in Africa? There's some options. Any suggestions? 54. Anyone for 55? There's a few hands. 56. So yes, so there's the answer. The answer is there's 54 official countries in Africa, but there's potentially 54 to 56 countries in Africa, depending on war zones and how countries are structured, Western Sahara, those kind of places. So yeah, so that's just sort of a little bit of an intro of Africa. The reason I'm telling you that is because I love Africa, I love its people, and I like technology. And I've personally lived and worked and traveled to 30 African countries. So all the places with the yellow stars we have been. As you can see, south, east, west, north. I've been to most places. There's a couple of places where I prefer not to go. But yes, I hope you can see your country there. If you don't see a star next to the country you represent, let me know. I'd love to go there and speak to you about it. Yes. Tunisia, I haven't been to Tunisia. Yes, absolutely. Great. So maybe just to start with the basic thing, just to talk about a couple of definitions. What is health? According to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. And then my second last definition is what is digital health? A little bit longer one, I'm going to read it. It's the systematic application of information and communication technologies, computer science, and data to support the informed decision-making by individuals, the health workforce, and health systems to strengthen resilience to disease and improve health and wellness. So that's the definition from the World Health Organization on digital health. So why is this important? And this is a quote from Dr. Tedros, from the Director General of the World Health Organization. And this is probably more important for me, is this quote that says, digital health is not about applications, platforms, and devices. It's about transforming how health systems serve people more equitable, more effectively, and with greater attention to individual needs. I think we need to keep this in mind when we look at this conversation around what do you do in digital health? What's the opportunity in digital health? It's not just about the tech. It's about actually making a difference and adding value to people on the ground in the countries and in our communities. So think about that when you want to do a startup or you have an early stage business, is what's the real impact you want to make and what do you want to achieve? And if you have a passion for something and you know why you are doing it, not what you are doing, then you'll probably be successful, more successful than just trying to build tech. So I've broken this presentation down into two components. The first part is around digital health lessons from an African perspective. And then we'll look at some opportunities, and you guys can then see how you can potentially apply some of these things in your environments. The first lesson is that context is everything. So the reality is that urban areas and rural areas don't look the same. And a lot of our solutions in digital health in Africa, beyond the big metropoles, beyond the South Africas, Nigerias, Ghanas, there are many other places in Africa with less infrastructure. But even in our country and in other big countries, infrastructure is a huge problem. It limits healthcare access, and people have limited connectivity in a lot of these areas. So you can have the best tech, but if you cannot connect people to the technology, you don't actually have a solution. The second thing is around language and literacy, where we obviously have a diversity of languages in Africa. We have different cultures, and we have to take all of this into account, be able to localize our solutions to communities. And then the third lesson here, or the third sub-lesson in this one, is around avoiding copy-paste models. So the reality is that things that work in first world countries, the US and Europe, don't necessarily work in Africa. And you can't just bring their solutions to our environment. We have to think about it really carefully, and we have to be able to adopt local or adapt to local environments. Like I said, is there connectivity in the area? Do you have to have an offline version of an application? Those kind of things. So that's lesson number one. Lesson number two is around infrastructure. So probably the most critical part of, or foundational part of infrastructure is electricity. So we have something called load shedding in South Africa. It's maybe a term that most people are not familiar with, or some of you may be, but it's basically where they switch off our electricity for a number of hours per day across the country in different areas, be able to distribute the load. But that happens in many other countries as well. So if you don't have electricity and you don't have solar, and we'll get to solar, you cannot charge your phone, or you cannot run your laptop, or you cannot run the data centers required to be able to manage these projects. So reliable electricity is a key factor in a lot of these solutions. Second one's around internet and mobile coverage. So again, we need to consider that some areas don't have good local coverage and connectivity, although that is actually getting better across many areas across the continent. And then the last thing is we must avoid making assumptions of readiness. We shouldn't assume, don't assume that things are in place where your clients are and where your customers are going to be. Make sure you understand it from an infrastructure perspective and address those issues as well. It may mean that you have to put solar with your technology in a local community so they can charge their phone, as an example. Lesson number 3 is around mHealth and mobile as the gateway. So I'm sure everyone knows that mobile is becoming such a big thing across the globe, but specifically in Africa. And I think in a lot of places we have over 80% penetration of mobile phones. And in some of the countries, as you may know, a lot of people have 2 or 3 mobile phones, different networks in different parts of the countries or depending on who they want to speak to. So mobile is absolutely essential to consider when you build these solutions in the African environment. And mHealth, or mobile health, what it stands for, it's clearly been proven to add value in healthcare and in digital health in Africa. And things like SMS reminders for patients' appointments, online bookings, telemedicine, telehealth, those are all things that can be driven on an mHealth platform. So there are hundreds of apps in that space, and we can touch on it a little bit later again. But mHealth is an important consideration when you want to build something in this environment. And then mobile is obviously an enabler for scaling. So just 1 or 2 examples there again. You can capture a lot of data very quickly through mobile applications. So in the COVID pandemic, mobile phones were used to capture data in communities, to give it to community health workers. So it's a tool that we should leverage and not underestimate in this environment. Next one is around interoperability. So I think what's important here in this lesson is that we should avoid silos. So don't work in isolation. Don't work without consulting people around you, consulting communities around you, because it's all part of a bigger ecosystem. You have to figure out how do you fit into the healthcare ecosystem, how do you fit into the digital health ecosystem, and how do you connect yourself ultimately to the rest of the value chain. Because you'll probably solve for something, a little piece of the puzzle, and not for the whole puzzle. The second thing that's important is that we have to try and work within national frameworks and frameworks for governance, frameworks for safety and security, and standards that allows you to ultimately work with government and work within corporates, work within NGOs. So make sure you understand the legislation locally. Make sure you understand what the standards are for you to be able to scale your solution within those environments. And then ultimately, we have to create long-term value. So as I said, once you've embedded yourself into an ecosystem, it's a lot easier to scale your solution. Lesson number 5 is around trust and data protection. I think one of the biggest and hottest topics at the moment is data privacy and data security. And we all know how big that problem is globally. So I'm not sure if everyone knows, but healthcare data is the most valuable data that's available globally. It's even more valuable than your financial data. And that's why a significant number of all the hacks globally is healthcare related because of the value of that data. So we have to make sure when we build solutions that we protect the patient's privacy and that we protect that data as well as possible, as good as possible. Second thing is that we need to be able to align to local legislation around data, privacy, confidentiality. So in South Africa, we have the Protection of Personal Information Act. In Europe, they've got GDPR, the General Data Protection Regulations, and then there's HIPAA in the US and many others. So you have to figure out and understand what's relevant in your environment. And if you don't have this kind of legislation where you are, you want to be able to align to what's best practice. So GDPR is best practice out of Europe. We aligned, a lot of companies you all align to POPIA and GDPR and sometimes be HIPAA compliant. Because if you can apply those standards, you would definitely be able to comply to your local standards. Second thing is around consent. So you can only share patient data with anyone else with the patient's consent. So make sure when you build solutions that consent and terms and conditions is part of your applications. And it's clearly aligned again to the legislation, and the delivered to the end user in a way that they can actually understand it. So either in basic layman terms or in their own language, depending on where you are. But consent is really critical. And then the last thing, as I said, yeah, local law shape compliance. So use the appropriate legislation. The next lesson is about people. So one of the key lessons here is that technology doesn't solve problems, people solve problems. And technology on its own cannot solve any problem, but it's the people behind it. And it's also the most challenging part of delivering and deploying and implementing solutions is working with people. You have your early adopters on the one side, the middle that sort of follows, and you've got the people on the other side that don't want to change. And you have to know how to work with each of these groups when you deploy your solutions. So you want to start with the early adopters. They are the champions. They are the ones that's going to promote your solution. They are the ones that are going to test it. And you've got the laggers on the other side. It's going to take some time and effort to get them involved and on board. So yeah, that's the technology. In training and retaining of talent, I think one of the challenges we're facing in healthcare today is that we have a huge scarcity of people. And the workforce is getting older and older on the nursing side, also on the doctor side. So, as you guys know, in Africa, the ratio of doctors to patients, nurses to patients is a lot lower than in other parts of the world and in the developed world. We have to take that into consideration. But that's also an opportunity where technology can enable the ones that are there to make them smarter, to make them faster, and to be able to take the administrative load away so that they can actually see patients on the ground. And the last one is around digital literacy. So we know that a big part of the workforce, including our own, have never used a tablet and a laptop. They only have a phone. And many of them only have feature phones, not even a smartphone. So we have to teach people how to use a tablet and a laptop first before we can teach them how to use any software, whether it's Excel or PowerPoint or anything else. It doesn't matter. So teach people basic digital literacy, get them to trust the technology, and then you roll out your solution to the various environments. Next lesson is around sustainable financing. So the reason many pilots and POCs collapse is because they do not have enough money. As you can ask Yaseen and many others of us, it's expensive to build the technology. It's expensive to build solutions, and it takes a lot more time and it takes a lot more money than you actually expect when you start these ideas. So make sure you have enough money to build your solutions, and make sure you partner with the right people to be able to access funding as it's required over time as you scale your product. How do you embed yourself in governments and insurance models? That's a difficult one if you're a small business. The same applies for corporates. It's very hard for startup companies and early stage businesses to work with governments, to work with large NGOs, and to work with corporates because of the risk profile of those organizations. But again, the more you align to their standards, the easier it would become to engage with them over time. In our environment, we're a big corporate, but we do work with early stage businesses, but they sweat a lot because they have to comply to a lot of compliance and a lot of cybersecurity rules and not a lot of data protection rules. So the better you understand that environment from the beginning, the better you can plan for it and scale your own projects. And then the last thing is you have to build financially sustainable solutions. So you have to look after that money. You can't spend it all on bonuses and parties in the beginning. You have to be able to use that money to actually run operations and to bootstrap some of these projects until you get to a point where you can generate revenue. Last few lessons, local innovation works best. So very important for us to have context-specific solutions. And there's no one better to do that than the people that's actually from this environment and it's actually on the ground. And what we've seen in the past 20, 30 years is that a lot of technologies were built by technology companies and tech engineers and data scientists, but people that are not from the industry. So they build solutions that are great technologies, but they don't actually work practically on the ground in healthcare, or they don't follow the workflow of how healthcare works in our hospitals. So context is very important, and make sure you have subject matter experts in your in your teams when you build these solutions, so they can actually give you good advice as to how to roll them out. This is just one example of a good story in South Africa. Mom Connect app that was built to engage with mothers, pregnant women during the course of their pregnancy. It's a WhatsApp-based solution, and it's got a big traction in South Africa. And I think they're actually running out to a couple of other places in Africa as well. But go and have a look at Mom Connect. It's an interesting use case. And I think the last thing is we have to also build local ecosystems. So in South Africa, we have a number of incubators, we have a number of startup organizations that try to bring these things together. But even here in South Africa, the digital health space is quite small, and a lot of the people know each other, and it's quite hard to grow it. So, and the same applies to other countries. So you have to figure out, how do you create local environments? How do you create local places where people with common interests can get together, even if you start in a coffee shop, and then grow to something bigger and get some people to start talking to you. But it's important to consider these things. Second last one on lessons is measure impact, measure impact, not input. So it's important for the funders, for the governance organizations, for the corporates to see how you actually create value out of the businesses and not just see the numbers. So it's not only about how many SMSs you've sent, how many people was on your platform. It's about how did it actually impact them? How many lives did we save? How many people did we give medicine to? So think about that when you build these solutions, to measure outcomes and impacts rather than just inputs. And then obviously tracking real health outcomes, as I mentioned, it's access to care, it's equity, it's patient safety, it's patient quality. Those are the kinds of things we need to consider. And then build evidence for scale. So make sure, as I mentioned, that you build the solutions in a way where you tick the boxes of the bigger players. And it is quite hard. The last lesson I want to touch on is collaboration over competition. So it's important to partner as much as possible, and sometimes even to partner with your competitors, because there may be synergies between what you and someone else is doing. So even if there's overlap in some of your technology or some of your capabilities, there may be things that's unique on your side or on their side. So try and partner with people like that and learn from other people that's in your space. Try and partner with multi-sector collaboration is around partnering with different groups, government, private sector, academia, NGOs, and other commercial organizations. So really think about that, because partnerships are key, and other people and like-minded people may just open the door for you that you don't have access to. And next time you'll do it for them. So think about these partnerships. So those are the 10 lessons I wanted to bring to you. More sort of boring. Let's go to the more important stuff. Perfect. I'll just jump through some of the opportunities quickly. So the first opportunity is telemedicine and virtual care. Now I think you must start thinking about, what can you build? What can you do with these technologies? So telemedicine bridges the gap between rural and urban areas. It connects patients to doctors far away from where they are. And it's a platform that works on a mobile phone and on a tablet. So think about that as an opportunity. The second opportunity, as I mentioned, is mHealth. So mHealth can be used for early detection of diseases, for screening of patients. You can start integrating with AI solutions to do symptom checkers, those kind of solutions. You can triage patients in emergency centers. So use mHealth solutions. Start thinking about what app you can build, but build apps that's context specific in your environment and that actually address a problem in that environment. Third one is AI, and I'm not going to spend a lot of time on AI because that's a topic on its own. But AI has the ability to enhance healthcare diagnosis significantly. So this is just one example of using AI to diagnose specific diseases on a chest X-ray. So imagine you don't have a radiologist in your environment. How can you use AI to help you with screening so you can get the right patient to the right doctor at the right time? Only other thing I'll say about AI is, and doctors, they say AI won't replace doctors, but doctors that use AI will replace those that don't. Just think about that for a second. And the same apply for nursing. Digital health records, big thing at the moment in South Africa specifically, but also across the continent. We are currently probably sitting on 90% paper still, even in South Africa, and we're slowly digitizing now. But if you don't have electronic medical records, you actually can't capture the patient's continuum of care. And you cannot provide integrated care for a patient if it's not digitized. So digitizations can become a big thing over the next 5 to 10 years across Africa. So think about how do you get involved in development of electronic medical records. Then mobile money. Mobile money helps us to expand access to care for patients. So examples will be there where they can do cashless payments for medical services, where you can collect your insurance vouchers, where you can get insurance premium collections, and many others. So yeah, mobile money, I think, is an interesting space. There are many players in this space, the M-Pesas of the world. Think about how you get involved in this environment. In drones and smart logistics, some of you may have heard about this company, Zipline. They've rolled out across Rwanda, they're in Ghana, Nigeria, where they're delivering vaccines, medicine, blood to remote areas. And that is one example of how you can overcome infrastructure barriers, how you can deliver things in remote areas in a sustainable way. So this is the kind of thing you must think about in this environment where there's limited infrastructure, limited resources, but we can scale this across an entire country in a very short period of time. Big data and health analytics. If you play in this space, population health, knowing where things are happening, knowing where outbreaks are starting, that's the kind of opportunities you have in the big data space. And then from big data, we also get to personalized medicine. So if we start looking at genomics and gene sequencing, the space that's also here, a very interesting space that Richard will tell you more about. But the more you know about a person, the more accurate healthcare you can provide to that person and more directed at their specific conditions. Wearables and remote monitoring. Again, this fits in with telehealth, telemedicine. We have the ability to now monitor patients at home in the same way that we do in a hospital. So if you don't have a hospital in your area, you have the ability to monitor patients in their own environments through a call center, through a contact center, through providers that are remotely based away from those patients. So think about remote monitoring, think about wearable devices. Last two slides is on e-learning and digital training. So I think this is a very important thing in Africa, is empowering our healthcare workforce and empowering our communities as well through education. So there are many open source e-learning platforms, but content is the key to providing these solutions. And I think Yaseen will also speak to content and training and CPD, continuous professional development, as important components of the healthcare system. And finally, as I mentioned, partnerships and innovation, build innovation hubs, come to places like this, drive your local innovation, and really partner with people around you. That's how you learn, that's how you work together. It's hard to be a startup, it's hard to be an entrepreneur, and it's a lonely world when you are the CEO and the salesperson and the HR guy and the developer when you start these organizations. So yeah, and I'll just sort of wrap up with a comment coming back to me, why are we doing this? And this is what Bill Gates said. He said, if Africa seeks prosperity, it must provide for the health and nutrition of all, including the poorest. So I urge you to think of solutions that actually helps the masses, and not only those with money and those in the urban areas. So that's where the opportunity is mostly, I think, in Africa over the next couple of years, is coming up with solutions for the masses that is scalable, that is cost effective, and that actually makes a difference. Oh, thank you. I think that's what I can give you in my half an hour. Thanks. I think the floor is open to questions now, Richard.
Questions, guys. Great. Put the hands up again for questions. Oh, lots. This half of the room again, hey? Do you want to keep, let's do the first two and then I'll move.
Thank you for the presentation. I have two questions. The first one is on if a patient has, like on mHealth, they have an account and they have maybe presented one condition this year. and then next year they use it again? Does the account track them and have the information for follow-up? Maybe this time the person was having a flu, and then the next time maybe he's having cholera, and then there are different things. And then if this information is contained for how long? That's also a question into. But then the second question is on e-learning. And have you tried to cater for people who cannot talk and then those who cannot see?
Thank you for your 3 questions. But let me answer those questions first, otherwise I'm going to forget. The first question around data capturing, that's the value of electronic medical records, is that someone can come to the clinic today and you capture their first diagnosis, and in a month's time they come with something else and you capture their second diagnosis, but it's all in one record. That's the challenge we're facing today, is that patients go to clinics that are paper-based and they present in clinic number 1 today and they get antibiotics and they don't get better, but next week they go to another clinic and they get the same antibiotics again. And that complicates the patient's treatment, actually. So the moment we have electronic records and we digitize the solutions, we have the ability to get access to the full record of the patient over time. So that's how we do it. In terms of how long you keep data, I think it depends from country to country. In South Africa, we're keeping a lot of our clinical data for 7 years. But if you are a newborn or a child, we keep those records for 21 years. So it depends. In chest x-rays and mining, we keep for 40 years. So it really depends on the local legislation, I think, how long you keep records, but more than 7 to 8 years. And then the third question around the e-learning, I've not specifically worked with any solutions that caters for the blind, the deaf, but I mean, on the deaf side, I think people can still read and people they can do a lot of presentations where you have subtext in those. But yeah, it's an interesting challenge that I think you need to consider as an opportunity.
Okay, thank you very much for the talk. My question is around one of the lessons that you learned in digital health in Africa. You mentioned that there is need for infrastructure, that is the data centers, and also you mentioned that there is need for power, electricity, and also if you have infrastructure, of course, data centers, then you need to put data there. So there's no need for you to copy and paste the data that has been generated maybe in Europe and so forth. So my question is on the feasibility of this, because looking at availability of electricity, I think is a problem across Africa. There are a lot of power cuts. And in South Africa right now, I feel like, okay, it's much better. But in a country like Zimbabwe, you might go maybe for more than 12 hours without electricity. And also looking into the fact that one type of AI, which is generative AI, is worth more than $4 trillion, and the total GDP of Africa is less than that. So how do you see us as Africans, catching up, considering that energy is a big issue in Africa? I don't think if you want to invest in energy, as countries, it's going to be very feasible. But are there conversations around maybe as Africa, say, let's invest in power, let's invest in data centers, and so forth? I just want to know if there are conversations around that, because these are the lessons that you have, but are there conversations, or what are the steps that are being taken to at least address that big problem that can hinder the adoption of?
So I'm going to try and answer thanks for those comments. So I'm going to try and answer a couple of those comments. So I think we have to be practical in how we address these problems. So you may not have electricity in an area, but you can get a small solar panel that doesn't cost a lot of money and a small battery and still generate electricity enough to power a phone, to power a tablet in a community. And you may have to share that device amongst people. So I don't think we're going to get electricity and infrastructure everywhere miraculously that quickly, but we have to come up with alternative solutions to address that, to be able to get access. And even if you don't have power for 12 hours, you can still charge your phone during the other 12 hours and have it available during the time of no electricity. Your AI question, ChatGPT, yes, it's a lot bigger than than we are. I think the benefit and the beauty of mHealth and mobile health is that you can scale a solution. There are hundreds of millions of phones across Africa. And if you can send an SMS to one, you can send an SMS to 1 million. If you can deploy your link on WhatsApp to one person, you can deploy that link to 1 million people. And we know that almost everyone's got WhatsApp on their phones today and already communicating with that. So I think the AI is an enabler, but the mobile phone is actually the tool that's going to deliver that solution to you. So I don't see that as a big issue. I think we have that ability to scale with the technologies that are available, and we must leverage those technologies. Yes. Yes.
Good day, Doctor. Thank you for the talk. Just wanted to look at opportunity number 7, big data and health analysis. Looking to use South Africa as an example, how much data do you think we would need to implement that into our healthcare system and also to effectively train AI for diagnosis in an African setting?
That's a difficult question to answer. Thanks for that. So I cannot tell you exactly how much data we need, but I can give you 1 or 2 examples. So one of the biggest radiology AI solutions in the world is built in Australia. And they trained the model on 200,000 vetted x-rays. So every one of those x-rays was reviewed by a radiologist. So this one's got TB, this one's got pneumonia, this one's got a collapsed lung. So that was 200,000, but sometimes people train their models on 10,000 of something, and sometimes a lot more. If you look at these big LLMs and the ChatGPTs of the world, they use a lot of globally available data. So how much data we need, I think the question is not necessarily at the moment how much data we need, is like, where do we get the data from? Right? So how do we capture that data? Because it's on paper at the moment in many places, in government and private sector, in healthcare specifically, and that applies to South Africa as well as most of the other African countries. I think that's the question we must answer, is how do we collect the data? How do we digitize first? And what's important to digitize, because you don't need the full record necessarily, but it's essential components from that. Hope that answers your question.
Okay, thank you, Fanie, for that very good presentation. My question is looking at health patterns in Africa. We know that there is a big gap of missing data from health records outside the hospital. So how do we, and how can we harness that data to be incorporated into health for Africa, and also to include it in part of hospital health data?
Okay. Answer first?
Okay.
Thank you. Just a few questions. It's concerning regulation. You know, we have a lot of tools, we have a lot of approach, so, you know, in clinical approach, we know we have ethical committee, you have all those regulations, but in AI, I don't know if you actually have an regulation. Everybody can do everyone, if every tools, I don't know. In your own experience, there exists an regulation committee or something like that? Thank you.
Thank you. So yeah, let me ask you a question first on clinics. So a very, very important question, because there are a lot more clinics than there are hospitals actually. So the majority of the primary healthcare data are sitting outside of the hospital system, and we don't know what's happening there. So again, the same problem, it is still on paper. So the way we can potentially solve it, and that some people have actually solved it to a degree, if you look at organizations like the Gates Foundation and others, they've rolled out mobile apps to clinics where they just look after stock. Basic stock. Do you have HIV medicine? Do you have malaria tablets? Where they roll out screening tools for malaria, for HIV. You take a picture, you send it in, someone can assist you with the diagnosis. So I think we can create basic tools that capture basic information of patients, a diagnosis. You don't have to go through all the detail, but we want to know you've got pneumonia. We want to know you've got TB, you've got diabetes. Because if we start capturing that, that feeds into the hospital system. I think it can add a lot of value to the people that's got to make decisions around the patient's care. Then your question on AI. Got it again. Ethics, ethics in AI and the AI legislation and regulation. So to give you an example, in South Africa, in our environment, we are busy developing an AI policy and framework policy for how do we use AI in our environment. So organizations will do it individually, but at a national level, it's also being done in government, but also in the organizations that drives these platforms. So in South Africa, it's SAPRA. They are responsible for registering medicines and devices. And AI tools are now seen as medical devices. So you actually have to register your medical device with SAPRA to be able to use a tool, an AI tool, to provide analytics. But it's early days for them as well. They've just launched their AI regulations. So I think that more and more of that will come to the fore as we develop and as we learn from each other, because we don't have all those answers yet.
My question is around profitability, as the whole purpose of building a business is at the end of the day making profit. And we all know Africa, there is a huge need and demand for some of these solutions, but you find that majority of the people that these solutions are targeting are unable to pay for them. With regards to the avenue where you told that we need to find a way to integrate ourselves in both government and insurance. For government, usually the biggest problem is they are very hyped about pilots, but not a lot of them are willing to go past that. With regards to insurance, the other problem is usually around the startups themselves, because they don't know if you will be there at the end of the day or 10 years to come. So they are usually very hesitant to back everything or bet on you. So
I'm not going to ask. Yes.
Okay.
Yes.
Thank you, Doctor, for your talk, and thank you for the lessons that you share too. And clearly from the lessons, we can get that digital health in Africa is facing a lot of challenges, leveraging government's laws, data, how to get it, where to put it, and how to deal with it, and the lack of foundation in most African countries. So it's hard to talk now about implementing AI in diagnostics while you don't have the basics to even introduce technology to the health market in Africa. Why do you think it's worth the effort to do all of this work in the African context? Because to catch up, we need to work harder and work faster to get to where other countries are now.
So a very good question. Yeah, it is a very good question. I mean, Yaseen can also give his view on this one. I think we need passionate people that really wants to make a difference in our communities to solve these problems. So if you are passionate about healthcare and you care about people, I think we can come up with good solutions. And it is hard, as you said, to make it sustainable, to make it scalable. But if you can overcome those barriers, and a lot of it has been, a lot of those have already been sort of solved for to a degree in other places. We must just look around us and see where other people have solved for these things. So I think it's definitely worth doing it. I think you can make it sustainable. You can be profitable in rolling out these solutions. But it's hard work because you're going to need your own money in the beginning. You're going to have to have grit and keep pushing until you can get a corporate to sponsor you or a corporate to partner with you, or until you can come up with an innovative model of financing the solution, but also making money in a way where people can afford it. But I do think it's possible and worth it.
So I think we might be running a little bit over time today. If you guys have an extra 10 minutes, those who need to go earlier, you're welcome to. There's 2 questions online as well. I need my glasses now. First question is from Lima. Would you say that mHealth has been effectively scaled up in Africa for access and use for health services, for instance, among adolescents? First question. And the second question is from Julius from Malawi. How do we integrate e-learning in hands-on intensive professionals, surgery in the lab, for mHealth? How how can we make it more for the masses, where the doctors can see it more? Read that again. And for mHealth, how do we make it for the masses when it cannot work for certain diseases that require on-site doctor interaction?
Okay, thanks. So the first question is around mHealth and does it actually work in Africa? So I do think there are good examples. Like I said, the Mom Connect is an example. Millions of mothers have already used that application. That is in South Africa, and many of them are in rural areas, but they still have a phone and they still have WhatsApp on their phone. So WhatsApp is a great medium to build solutions on. You don't necessarily have to build the base infrastructure to solve problems. You can use an SMS, you can use USSD. So we must use these base technologies to create our solutions. You can obviously build an app, but if you build an app, you have to build an Android one and an iOS one, or you build a web application that are working offline. So there's, again, many challenges, but I think we must use what's available out there. We can scale mHealth in Africa. We have the phones out there, and we know what the problems are. So I just want to last comment on that around what do you solve for is don't reinvent the wheel. Before you try something or want to build something, just go and Google and see who's done it, who else has done it in other places, and learn from their experiences and try and do things better and smarter than they're doing it. And then it is possible to scale your mHealth.
I'm going to stop there and say, Fanie, thank you very much. You can tell by the number of questions, this is a very interesting topic. And I just want to say thank you very much, Fanie.
Thank you.
And while Fanie gets Yaseen's presentation up, so the next speaker is somebody who has lived this path for 10 years. And I first met them 10 years ago when I was at the MRC. We were the initial funder of this project. And what it was two doctors who had a platform that worked beautifully. They trialed it in Khayelitsha Hospital, which is a hospital not very far from here. It reduced patient mortality by 90%. What a great success story. The app worked. The problem is it was on Apple. It was on the Apple platform. No other government departments used Apple, so you couldn't scale beyond that hospital. Then it was, could we get the government to take it up? No, they couldn't, because they were a tiny group of guys that struggled to, how do you believe two guys are going to revolutionize the global health space? Insurance companies, the health systems, this is what Yaseen is going to come and talk to us about. So Yaseen is going to talk about the story of EMGuidance. I know this program very well. We were part of it in the very beginning, and I don't think there's a better example of how to make something scale in healthcare in Africa. Yaseen, you have 25 minutes, and then we will take 10 minutes for questions. Go for it.
Great. Fantastic to be speaking to you all. Richard, thanks very much for the invitation. And it takes me back a little bit. I am a student of Stellenbosch University, so I've been on this campus before. I did both my undergraduate year as a student, a little bit later as a postgraduate student in epidemiology. And I recall being in a class with mostly African students from multiple other African countries. And it was actually a very, I recall it being a very inspiring time. It was very much like you are a group of bright minds representing different contexts from around the continent. And we kind of, we alike, but we're different. Contexts are alike, but we're different, but it's one kind of shared African story. And what happens is that we don't have enough connection time to share the right kind of ideas and diffuse the right kind of knowledge. I've had the benefit of spending quite a bit of time out in the UK and out in Silicon Valley tech hubs. And what I notice is that there's an immense density of connection. And so I really appreciate these opportunities to kind of establish that on the African front. So as Richard said, I'm going to be talking to you about our story as EMGuidance. I'm a medical doctor by background. I am now a health technology entrepreneur. I head up essential medical guidance. I really don't have all the answers, but what I'm hoping to share with you is some of the mistakes that I've made, kind of translate them into lessons, and with the goal of hoping that in the context that you represent, that if you can take some of these lessons into opportunities of your own, then I would have sort of done my job. Good. Great stuff. So how did all this begin, right? I worked as a medical professional, worked in South African hospitals, primary care clinics, as a GP, as an emergency room medical doctor. And I'm sure as many of you experience, and as Fanie noted, context is paramount in healthcare across the continent. We just have very different set of constraints and on-ground issues. And that's a reality that one cannot ignore when developing any healthcare innovation or product. And the challenge is that when you move from theory to practice in the African context, it's quite jarring, moving from theoretical medicine to being a junior doctor and having to understand the constraints of lack of medication supply and specific policies with respect to care coordination and where you refer patients to, and dealing with a very vast and different disease burden, cost constraints, and then ultimately realizing that we, myself, colleagues, were not equipped with the kind of tools, protocols, and information to make the right kind of decisions in the coalface. And everything gets, significant burden gets put on medical professional shoulders. And what do? We typically go online and we try to make decisions. And we realized very early on that we were missing a kind of context-driven support platform for South African healthcare professionals. So what we did was we engaged our superiors, Richard, the likes at the time, and worked to do something very simple, to bring together all the information that a South African junior medical professional needed to know in one place, and make it very easily accessible. It was a large collaborative project. And so think of it as the heart of it is kind of a search engine, a clinical search engine, but that speaks to the local context. That's what EMGuidance was all about in the very beginning. And it hit a nerve. It hit such a nerve, and it was such a pain point among colleagues that it took off virally. And the collaborative aspect of the platform just started mushrooming. And all sorts of parties, universities, medical departments at medical schools, government started contributing to the project. And right now, it's 8 years later, the largest online platform in the South African healthcare space. There is a search of the system every 1 to 1.5 seconds. We cover the vast majority of healthcare professionals, 60% of registered doctors, but it's about 80% of all practicing doctors. Doctors are actually on the front line. Virtually every doctor under the age of 45 is on the platform. And it's in every small town, every city, hospital, every clinic, and across the private and public sector. So it's become a kind of relied on system. that speaks to local context. So what happened as well after a couple of years is that it got sort of the level of recognition by national government that because of the public good of the platform and it's being instrumental to clinical practice, it was actually introduced into South African law as a mandatory platform. Definitely on the pharmacy side. So every pharmacy in the country by law has to have the access to the platform. So this was just a really significant recognition to achieve a kind of government default country. So what's important is just to take a pause and speak to the underlying problem that the platform and EMGuidance addresses, because this problem I'm sure exists in your countries as well. And perhaps such a solution hasn't taken shape, right? And if you take a stand back, what is this all about, right? You look at the healthcare system and healthcare outcomes as a whole, healthcare professionals are inordinately responsible for healthcare outcomes. They are typically a small group of people. And in Africa, doctor-patient ratios are much more disproportionate than the rest of the world. So this problem is even more pronounced. So South Africa has roughly 50 to 60,000 doctors dealing with 60 million people. So if you support healthcare providers and you make them optimal and you focus there, you can have quite a significant impact on healthcare outcomes overall. It's important to understand, well, what's happening with healthcare professionals on the ground. So South Africa's doctor-patient ratio is about 0.79 per thousand. Just to put that in context, some developed countries may have ratios of 3, 4, 5 per thousand. There is an immense body of evidence that doctors are not optimal, right? There are a number of studies. These are just two recent ones that I will articulate. When it comes to antibiotic decision-making, a study in a particular province in South Africa showed only less than 50% alignment to empiric antibiotic standards. A major study in chronic disease. Chronic disease is one of the single biggest drivers of healthcare costs, hospitalization. Doctors were found to only optimize medicine treatment in diabetics 5% of the time. So I can imagine what impact this has on cardiovascular care, downstream healthcare costs, etc. So we're not getting it right. Healthcare professionals are not getting it right. Furthermore, the private insurance market, right? The doctors making decisions within the context of what he's paid for. And as a doctor, one cannot ignore that, right? You've got to align with the insurance rules, the funder rules. A major recent government report showed that there's just a vast disconnect. Doctors have personally no understanding of what is paid for, what's not paid for, how to optimize a patient within the respect of their benefits. Called the South African Section 59 report. This is something quite recent. And furthermore, healthcare professionals are significantly overrun. Right? They are inundated with patients because there are many more patients than there are doctors. They are inundated with digital systems. They complain about workflow interruptions. They've got to go to multiple different systems to get information from patients. So you take and sorry, the last point is that this is the largest medical insurer in South Africa, and significant survey, and 40% of medical professionals are burnt out. So if you take a step back from a public health perspective and say, well, if you've got this small repository of healthcare providers that are responsible very much for the healthcare of the nation, how is it that they are in this state? And what can we do? And how do we locate ourselves within this? So moving on, right? Our core app addressed a part of that problem. What it did was it made life very easy for healthcare providers. It stopped workflow interruptions. It told them what is safe to do. It kept them medico-legally safe, and it allowed them to optimize care. But it certainly doesn't solve, the entirety of the issue. So we understood that we had to build a broader platform, right? We had to build, the theme of EMGuidance is a digital platform to empower the frontline of healthcare professionals. How do we go about taking the starting point, the solution, the app that we've developed, build it into a sustainable platform, sustainable business, but keep the focus on uplifting healthcare providers so that they can impact outcomes within healthcare. And I'm going to talk to you a little bit about what that journey looks like, right? The starting point, interestingly enough, is money. And I say that very crudely because the market is a hard reality, and often the disconnect is that grant funding, donor funding to initiate projects may be devoid of the hard realities about what gets paid for, what does not get paid for, and doesn't really factor in a costly particular technology device, vaccine, genomic development, takes. So the stand back is, so how does money work in a healthcare system? Now, this is a view of South Africa, and it's an important view to be able to contextualize any new initiative or startup. So I'll put your attention here, which is, we call it medical schemes, but we talk about health insurance, right? Now, just South Africa is split between South Africa's public sector and South Africa's private sector. The public sector represents about 80% of the population, but it's got about 20% of the funding. 20% of the population is about 80% of the funding. So already you can see that if you're going to locate a solution, probably want to start with the larger pool of money. Also very difficult, as Richard will attest, for a startup to initiate business with government. It can be done, but it's extremely difficult. And so if you're getting into a healthcare entrepreneurship, really understanding where money flows from and what your payer market is actually like. And when I say payer, I mean insurers, funders, medical schemes. In South Africa, they spend about a R250 billion a year in medical aid payouts. And so that's where those contributions come from individual patients. And then insurers dish out that amount of money for all sorts of things, for hospitalization, for medicines, GP visits, etc. That's a very large pool of money. Pharmaceuticals are somewhere downstream, but medicines are a very large area of focus. You can see that the differences, there are about 70 billion rands worth of drug turnover in South Africa. And just from a currency perspective, that's probably about 3 to 4 billion US dollars. Hospitals and clinics spend about 100 billion rand. That's probably also around $5 billion. And the reason for putting this up is not really to focus on the numbers, but just to take a stand back and say that understanding the magnitude of spend and the differences in the different payers would really allow you to conceptualize where your business may work. There are a number of smaller areas of spend. We built an app and a platform for healthcare professionals. The amount of money that healthcare professionals actually spend comparatively to spend across major segments is just minuscule. So the key question here is, what problems could a technology platform, and if I bring it back just to this particular slide, challenging. Our starting point for commercialization was that, well, we've got a digital platform that encompasses nearly every healthcare professional in South Africa. We reach them at the coalface that's used in practice. How do we begin to commercialize that? Do we charge the doctors? Do we charge the pharmaceuticals? Do we charge the medical schemes? And how do we even go about doing that? Clearly, the kind of reach of the platform should be able to make, firstly, a public health outcome, but some outcome that ties to a commercial requirement, commercial problem. for any of the players. Sorry, this takes some time. And so breaking down the spend a little, and again, this will be a similar, there'll be a similar graph in very many of your countries. So where does healthcare spend go? And how does that tie into where healthcare needs to go? So this is a breakdown of medical insurance spend, which is the largest spend in the country. And what the breakdown says is that South Africa spends way too much downstream. So we spend on hospitalization, we spend on medicine, we don't spend enough on primary care, we don't spend enough on preventative care. And the medical market is at a point where healthcare costs have to come down. Insurers needed to come down, patients needed to come down. And what's happening is that this spend needs to be inverted, right? So you need to have much more significant spend on primary care and preventative care and prevent downstream health costs. That's where things should go. And that's where large players understand things need to go. But this is where they're currently spending money. So one thing you draw from this is that if you're speaking to an insurer, and an insurer's scratching their heads and they're saying, oof, I spend 40%, 40% of my annual funds on hospitalization. You've got to ask yourself the question that when I speak to them and they know they want to reduce that spend, am I talking a commercial language? Am I able to engage them to say my solution is able to address some of your biggest pain points commercially? In our case, but healthcare professionals around the country, one question we asked ourselves is, how do we ensure doctors do better chronic care across the country so that patients can be healthier, that we can reduce hospitalization costs from South Africa's largest insurers. And so the analysis and understanding of how money works and where spend goes allowed us a starting point to develop solutions. And that's certainly a key lesson. So what does the platform look like now as of today? So I spoke to you about the sort of individual or the focused referencing application. But it's a broader platform for healthcare professional empowerment, a digital platform for healthcare professional empowerment that incorporates insurance, medical schemes, incorporates pharmaceuticals, incorporate labor, and we train and educate healthcare professionals through the same platform. Furthermore, it's a very alive and connected platform. Healthcare professionals can message, connect, speak to each other, manage a profile within the platform. So it's effectively become a kind of a home base for healthcare providers. But commercially, mostly free for healthcare professionals. There are a few things that they do pay for. But commercially, we provide solutions to the insurance sector, to the labor sector, and the pharmaceutical sector. If they want to access the healthcare professional audience to drive commercial benefit and outcomes nationally, we have developed, I won't have the time to go through the detail of the solutions, but for example, a medical scheme can assist to run campaigns to healthcare professionals to run better cancer screening or chronic disease screening around the country. A large hospital can actually recruit healthcare professionals, optimal, high caliber healthcare professionals through the platform. Pharmaceuticals can launch a product. They've got a lot of rules for pharmaceuticals to engage in the platform, but they can launch a product, around the country. So we have to think very carefully about how money flows and what really moves the needle. And at the same time, keep the platform focused on healthcare professionals and uplifting them. Where's this all going and what does it look like? The single app now is more of what we call a clinical operating system. It's not a EMR, electronic medical system. It is a clinical decision-making system that comprises now a search engine, multiple different tools, the ability to connect between different healthcare professionals, manages your e-learning, keeps a profile of yourself, and growing. We have now set the platform up such that third-party startups and applications can get distribution through EMGuidance. So where others have developed clever tools, use it into this operating system and introduce it to the. But if we stuck to our vision of saying, how do we make sure that we empower healthcare professionals and that we access them wherever they are in the system? So besides the kind of open application, what we've done is we've modularized the platform and we integrate into workflow systems. So Fanie will know this because we constantly knock on Fanie's door at Mediclinic. But what we've done is we've said, we are decidedly not a practice system and an electronic medical system. We are a smart clinical system. So there are a number of modular solutions, either the data or the search bar or our smart digital prescription, messaging and referral component. And we plug that into other EMR systems. So on the doctor practice side, we are actually in the majority of practice systems around the country. So not only do doctors see the app, but when they do their workflow, they sort of see EMGuidance inside. So the goal is to be kind of an embedded and integrated platform. So this is just a view at this stage. I won't obviously go into detail, but we've managed to integrate as customers and partners the vast majority of the South African healthcare ecosystem. Pharmaceuticals, hospital groups, pharmacy partners, recently, insurers and medical pharmaceuticals as well. And where's all of this going? In Q1 next year, we will deploy our Copilot, our AI-driven Copilot, so that all the information in the platform is accessible through a natural language interface, essentially an intelligent AI-driven clinical assistant for healthcare providers, but one that is South Africa focused and safe and trusted within the South African environment with unique data and also having access to unique longitudinal patient data. So very, very intelligent clinical assistance for South African medical professionals. So from an expansion perspective, we are very focused on South Africa currently. But we do have organic uptake of the platform across the continent. And the goal is that probably in a year or so to actually put foot on the gas from an expansion perspective, because with the help of AI, given that it's worked in South Africa, we can greatly accelerate localization in other countries. This is actually the focus of our project. For the next couple of months, we need to do an expansion analysis, really look at which countries need the product, how quickly can we localize, what's the starting point commercially, and really across the continent. So some key learnings, right? Probably would have liked to get you a little early, but I'm going to go through the 5 key lessons in the 5 minutes that I have left. The first one is pretty obvious, right? That solving a meaningful healthcare problem may not result in a sustainable business. What's important here is that you pick a problem and that problem may actually not be a problem that is important to those that have the money to pay for it. And that's a hard reality we've learned very early on, and I think a lot of sort of healthcare and particularly social entrepreneurs don't do enough thinking on. The other issue around this is that healthcare has got a very complicated model when it comes to doing business and commercialization. If I sell you an apple, you make the decision to buy the apple, you pay for it, I sell it to you. It's a one-way transaction. Problem with healthcare, and this is in every country, is that the one who makes the decision, oftentimes the doctor, the one who pays, oftentimes the insurer, Sometimes the hospital has to make a decision. And the one who benefits is the patient. But sometimes the patient may not even be the one interpreting the benefit. It may be an elderly person and you're speaking to the family member. So there's so much complexity and so many stakeholders in identifying a problem and then identifying a solution that you've really got to understand who's paying, who's the benefit for, who do I need to generate demand with. That complexity really needs to be understood from a healthcare perspective, right? Company Rock Health, the US did quite a significant study around health tech startups around the world. Health tech takes 2 to 3 times longer than any other sector, right? What may typically happen is that healthcare companies would do several rounds of investment before they even get to growth stage, 6 or 7 at times. We've done six rounds over the last 8 years. And why is this? It's pretty obvious. It's a complexity around payer, stakeholder management. It's compliance. It's the fact that there's a significant burden of proof from a healthcare perspective, and there's just low tolerance for error. You pull all those factors together, things are going to take longer. So what does that actually mean? Fanie's point, your capital planning and your ability to maintain a team throughout that period needs quite a decided and deliberate plan. That's extremely difficult to put together, particularly in a context of uncertainty. Early days, you really don't know whether things are going to work. The length of time and the capital planning around it is quite critical. From a product perspective, one thing that's very clear, and Fanie mentioned this as well, comparatively to other consumer sectors or other technical sectors, healthcare is very much dependent on workflows and journeys. So at EMGuidance, we spend a lot of time sitting with doctors, watching what they do, going into practice, going into hospital, sitting with customers like insurers and pharmaceuticals. And only once you truly understand workflow and how they engage on the ground is your solution actually going to work. Fourth lesson is that getting compliance right is a strategic advantage in healthcare. Right? What happens is that in other sectors, it pays to bend the rules a little bit. It actually does. You keep moving faster because if you're selling sneakers, it doesn't matter if you get it wrong. With healthcare, the approach of rather do it properly or don't do it at all actually pays in the long run. The amount of things we do from a cybersecurity perspective, pharmacovigilance perspective, healthcare verification, evidence-based medicine, privacy and consent, the amount of budget effort to that and time that it takes is what feels like a roadblock is actually a strategic advantage. Last key strategic lesson is this. And often from science backgrounds, we have this thought that, well, develop something and, well, I've done a pilot and shows that it works, right? I've done my HTA product supposedly done my health economic analysis. There's no reason why this should not be bought. And it's such an important lesson, right? That the market is irrational. What actually shifts practice is very different. Right? The medical community has a very contorted way of visions, and it's very hierarchical. Often depends on a specialist or group of key opinion leaders influencing a consensus committee, and then that influencing practice. And when you go to the large corporates like pharmaceuticals, medical device companies, you'll see the playbook they use, which sometimes seems a little dirty. They understand that there's a particular playbook to shifting practice that's very different from the kind of ivory tower evidence-based medicine, scientific backgrounds that we come from. When you enter the commercial space, you've got to marry those two realities. Doesn't mean lose the science, but you are in an open market, and those realities are significant. That's probably the single most important kind of transition for me, coming from a medical and scientific background, and then moving squarely into a private commercial segment. So really, that's it. I've summarized the lessons here, but I think that's enough for them to go through. So thank you very much.
Yaseen, lots of food for thought. Questions. I'm going to open the floor to questions now. We'll start. I'm going to turn the lights on, Fanie, if you don't mind.
Thank you very much for your presentation. I'm curious about the steps that you had to take from an advocacy and practical perspective to landing EMGuidance on the Gazette for it being mandatory. I think it was a 13 June 2025 Gazette, so it's a recent thing. But how did you get it there? Was it pressure of everybody wanting to use it and then the government had to kind of consider it? Or where do you even begin to get that done? Thank you.
That's a good question. Maybe to start off with, the national government and National Pharmacy Council, of course, have as a process around this. So they've done their own independent research, pharmacy networks, pharmacists and stakeholders around the country. They understand what is really important. They make an independent decision as to what's important. And so they ran that process, and this was the result of it, and we came to hear about it without ourselves being aware at that time. However, to your point, 6 years ago, we were in our early days. I had realized that there was a challenge because there were other companies that had the same recognition. I felt that EMGuidance needed similar recognition. So I and knocked on the door of the council and politely asked them to help us understand what their fair process is, be tabled as a gazetted resource. And I kicked off a process at that point. And then we kept light touch with the council over the years to say, well, you know, this is where things are going and this is what's happened. And we didn't expect anything from it. But evidently, wheels turned somewhere behind the scene. As much as things did take shape, the action of engaging government and regulators is another. We've seen that not only with the Pharmacy Council, but regulators, government do listen. As much as they may not pay, it's worth in healthcare. It's worth engaging all stakeholders, and that lesson I do.
I'm coming to you. I'm going to give you a hand in the mic now. So I met Yaseen in probably 2014. And they had this really nice little app that worked very well in Khayelitsha. And you go to governments and you say, look, I mean, it reduces your triaging mistakes by 90%. Of course, you're going to want this. Okay. So it went nowhere, in fact, for the government. But then when they said, well, could you put the digital, the essential drugs list on this app because you've got all these doctors on here using it? And said, well, we can do that. The MRC funded that. Then you are traveling with ministers and deputy ministers who are taking out their phone and showing ministers of other countries this app, how it's being used, etc. So, but they are not your main customer, are they? I mean, so the message to your question about insurance companies and medical aids, etc., it's not governments who sustain these things because they don't want to pay for the maintenance and the upkeep generally. It's the private sector. So I'm going to give it now.
So my question again goes back to the insurance sector and the medical platforms that are trying to address some of these solutions. For us, we burned through our runway trying to chase this, whereby we found out that in most instances, you find it's doctors themselves and patients who actually collaborate to fraud some of these insurance sectors, whereby we were having a conversation with one of them, and they were telling us that our solution is perfect, but it will, in the long run, hurt them more than it will help them. Have you had an instance where you've dealt with this, and how did you solve for it? And the second question is around workflows and journeys, how you map it. Most of this, you'll find that it is labor intensive and also very heavy on the cost aspect. For startups, most of them usually do not have the funds to be able to give them that deep knowledge of understanding of some of these workflows and journeys. Because there is also the aspect of trust, whereby even approaching the hospitals themselves, before they let you into understanding how everything works, you have to be able to prove why it is you want to solve for this problem and your intentions long after. How would you advise startups in the space?
Maybe I can Fanie address and then so and I think maybe just dealing with your last question first. This question about startups engaging large corporates and coming across as stable and having longevity and building trust. This is a critical one. I mean, a challenge around the world. Many societies do appreciate that innovation comes from startups, and so all around the world, healthcare, particularly in healthcare, corporates who tend to understand that if they're not going to partner with startups, they're going to fall behind the curve. That may be different somewhat in our context, and understanding that as a starting point is really important, right? But I would say it like this, right? Whatever the customer perception is, it's your job as the startup owner and driver to manage that perception. The commercial reality and the commercial interface has got a lot to do, sometimes more to do with perception than reality. What I'm saying is, I'm not saying lie, but I'm saying that they need to feel safe. And often what startups do is they're so focused on the product and the technology that they forget that there are simple things with respect to the perception of the company, how you rock up, who your partners are, who your potential investors are. You have a proper website and address, and you can get a long way by managing perception in that respect. What I would add, though, is that that problem is far more acute for customer number one. Right? It's usually customer number one that has that challenge. The second you have one customer number two doesn't often care because they just say, oh, well, that customer trusted them, so I'll trust them. That dynamic plays out over and over again. So if you pick a reasonable first customer that's relatively credible and you do whatever you need to do to get through the door with them, the problem typically goes away because it's de-risked in their mind. So, I mean, I can't speak for every context, but I do think those are some ways around it. And then you spoke about workflows, journeys, and how we do that. I don't think there are lots of methodologies. We typically do swim lane diagrams, as they call it. And so we map patient, we map doctor, we map hospital manager, and we use a lot of whiteboarding software. If that's the sort of the question that you're asking. And online collaborative whiteboarding. We, of course, used whiteboards, but it's quite intense now. Sometimes we even share it with customers. People will post Post-its and little stickies and things online. So we get very far with that. Yeah, I guess the focus is just on making sure that you're as close to the potential user as possible, and then listen more than you sort of put ideas for. So listen and watch. And only once you've taken enough in, then throw it all out.
The last question in the room, and I have several online.
Good day, Dr. Khan. I just wanted one question. So first one with the AI integration. I saw you just skipped over it. I understand. So I just wanted to know what kind of data would you actually be using to train the AI model? Because I have a feeling that patient data might be used. And if it is, how did you get around the regulations around using patient data? And also with NHI looming, how do you advise your private sector partners on how to adjust their business models with the information that you currently have?
Thanks for asking the AI question and the data question. That's really important, right? The starting point for us is that AI is a new technology, but it's not solving a new problem. We are focused on making sure that we can provide technologies to assist healthcare professionals in decision making within different contexts, in a hospital context, in a primary care context, for example. What you see in terms of AI from a consumer perspective is not 100% applicable for the local context of care and compliant within workflow. So the main issue is that by nature, the AI models that we use, conversational agents, they are by nature non-determinate. What that means is that it's frankly impossible to predict what the outcome is going to be. You put a clinical question into ChatGPT, you'll probably get a reasonable answer. But you as the healthcare professional, and according to South African guidance, you cannot actually trust it. Its nature is non-deterministic. It's a reasoning agent. So that's like an underlying philosophical problem, because what happens if you get a dose 1 degree wrong? Right? So you and the South African guidelines are very clear that you take on the responsibility as a healthcare provider. So how are we looking at it? We're working backwards from compliance and guidelines and say, what kind of AI system would we need to create to be safe, that a South African hospital can trust and buy from us, right? Because they can't put ChatGPT in their system. And the truth is that if you scale things back a little, right, and you try to operate more on the deterministic end of the spectrum, which I mean by this, and I've skipped over it for time, but I'll cover a little bit of detail. Where do you use AI in the system? One of the most important parts that we're using AI is to interpret the question, not necessarily fully reason the answer. And so a healthcare professional would ask a natural language question, and we'll break that down into actionable queries, and then ask the healthcare professional, is this what you meant? And then we source deterministic answers. So we can source an answer from a guideline, or we can extract a particular answer. And often we synthesize an answer. So we can say, this is what the national guidelines say, but these are the funding rules associated to that. So we really create a response that is conversational, but much, much safer. And so what that means is that there's no actual model training, so to speak. Yes, there's not model fine tuning, but there's certainly, optimizing and setting up of the system. Now, your second point was on patient data. So the main issue in South Africa and all over the world is about consent, right? And engineering around consent. We are not necessarily integrating and aggregating patient data and passing it into some black box for another healthcare professional to use. The way we're looking at it is pinpoint at that point, is there some patient context? So what medical aid is the patient on? What is their past medical history? And at that moment, can we use that data to drive a better decision? That happens between doctor and patient and system. It doesn't take the patient data and throw it into a broader black box. So there are ways to, again, work within regulatory constraints and design and optimize completely new systems that work within the regulatory framework. And that's our goal. And if that means that we can't get as good as ChatGPT, then so be it. But we'll deliver something that a hospital can trust and buy. And then we can sustain our business. And if in time the technology improves and it's a bit smarter and less unpredictable, then we'll advance at that point. I hope that gives you some insight into our thinking.
You're going to be staying here for a little bit afterwards if people can ask you more questions. That's okay. So we have 3 questions online, but maybe just illustrate this point. When I met Yaseen in the early days and this EMGuidance, before it was EMGuidance, it was called the Essential Medicines List. It was an app that you could download, and the Department of Health, going with the first meeting to the Department of Health, look, we have about 50,000 users, and last weekend we had 150,000 people a day looking for stuff. And they weren't interested in how many people. They looked at the data and said, we're very interested in the fact that the app is used mostly between midnight and 4 o'clock in the morning. What does that mean? Well, we're not really sure. Those are the doctors who by themselves at night in the hospital with no supervision, and they needed to double check the information and the dosing that they were using. So the government were very interested in the data, but not the data that we think they're interested in. So we have 3 questions online. First question is the easy one. It's from Abel. How can one access the application from Benin? Okay. George, I'm going to butcher your surname, Dr. Georgie Baragesi. How did EMGuidance bring about healthcare provider behavior change in the initial days after moving from paper to digital? And the last question is from Makina is, are you involved in any public-private partnerships ecosystems in South Africa?
So regarding Benin, the application is available through app stores globally and online. You'll simply have to register. What happens is that there's a process to put your healthcare professional details in internationally. Where we don't have verification processes in certain countries, you will get in, but you'll see a very limited amount of content. So you will have an experience of the platform. In many countries, it won't be localized, and your experience might be limited. And those are some compliance kind of aspects that we have. But if you want to kind of get a feel
in short, go to EMGuidance, find EMGuidance on the Google Play Store or
Google,
whatever.
Apple App Store, and you find it and you download it.
Okay, next question. Public-private partnerships in South Africa, are you involved in any?
Yeah.
And how did you change behavior by moving from paper to digital?
On PPPs, most definitely over the years. Typically, so I'll give you a couple of examples. We've done quite a bit of work with national government and the TB Directorate on MDR TB training. That was a private-public partnership with Johnson & Johnson. I think they were trained about 2,000 healthcare professionals around the country on multi-drug resistant TB. There's a good example of working with pharmaceutical public health departments in pharmaceuticals, working with government. So quite a few such initiatives. I would say that our main relationship with government is a PPP right now. So we don't charge government for the National Department of Health guidelines, but we deliver a service. So we sustain ourselves in the private market, but we offer a government service, and they endorse the platform and they see us as a partner in that respect. And then lastly, behavior change. So the very early days, there was not a lot of science or tactics. The problem that we were solving was such a significant problem that there was quite a bit of word of mouth. It was viral and word of mouth. Really, we didn't do much. But what we did do was our partnerships with influencing institutions, academic institutions, universities, and government has absolutely helped to drive adoption. Healthcare professionals see these leading institutions on board and get a circular from national government, and that certainly helps with.
So for those of you who are not doing the project, we will definitely link you up. And for those of you who might want to scale a platform in your country in Africa, chat to Yaseen. That's the plug, and those online as well, of course. But I just want to say thank you very much, Yaseen, and to Fanie for coming in and giving up an hour or 2 hours of your time. This is really going to be a transformative space in the market space. But one of the key messages from this session was to dispel the myths of how sustainability comes around. It is not winning a government contract to sustain you for 3 months or 6 months. Governments tend to pay late or never at all. One hospital in one district doesn't talk with another district, etc. And I'll give you one slight example. The TB app that we're talking about. In my past life, I chaired a committee for the government called was the TB think tank. It was all the government departments, etc., all the funders, and I was chairing the devices and medical products. And there were people came up and gave a very nice talk about their app that they had developed for TB adherence to treatment. 7 different apps, 7 different funders. They all worked beautifully within a hospital or a district, couldn't scale beyond the next postcode along. So there is lots of this pilotitis going on in Africa. They work beautifully in a small district, but they will never scale to sustainable businesses. So really, this session was really around digital health has got so much power in Africa, but how do you use it in the right context? And really, it's the benefit, I think Fanie and Yaseen mentioned, it's the benefit that the people buy into. It's not the data. It's how will it save us money in the healthcare system? How does it prevent people coming to hospital when we save ourselves 5